Good evening, and thank you organizers for giving me this opportunity to present the role of NGS in MET detection. Today, the MET has been targeted because of the therapy. It is being used as a biomarker, and it is now considered to be an established biomarker when you are doing a whole spectrum of NGS profiling. So, other than EGFR mutations, now we can see there are many of the targetable oncogenic driver mutations are available, like ALK and uncommon mutations. And when there are no targetable oncogenic driver mutations, you would like to go look for the PDL1 and the other immuno-oncology biomarkers. So, as I said, that other than EGFR sensitizing mutations, you get to see the uncommon mutations in very small percentage like ROS, RET, BRAF, and ERBB2. And in the MET exon 14, you can get to see the MET amplification as well as the MET exon 14 skipping, that is the splice mutation, what we call it as. And it is comprised of around 3% of the total mutations. So, ERBB2, as I said, is also another important emerging biomarker which is coming up. But today we will just concentrate on the role of MET in the by detecting through the NGS method. So, what exactly is the MET? It is a proto-oncogene which is located on the chromosome 7, and it encodes a receptor tyrosine kinase which activates the downstream signaling pathways, as you can see over here, like including MAPK, PI3K, AKT pathways, STAT, and NFKB pathway. So in normal conditions in the MET pathway, you get to see the activated binding sites with the hepatocyte growth factor, and with this hepatogrowth factor binding of this ligand, the MET pathway gets activated for the down signaling pathways, down signaling cascades of this MET, PI3K, and other RAS, ERKBB pathway. And this the role of the MET exactly is to regulate the cell survival, proliferation, and motility, and it also contributes to the both physiologic and pathologic processes. So, when there is a pathologic activation, that is when there is a aberrations are present, genomic aberrations on this MET pathway, that there is a tumor cell migration, and through this tumor cell invasion, you get to see the tumor cell proliferation as well as the angiogenesis. And this is how, like, what is the distinct mechanism of this MET dysregulation? You can see it over here. In the normal, when there is a binding of the ligand with the hepato growth factor receptors with the MET, you get to see the receptor activation, receptor internalization, and the receptor degradation. However, when there is a constitutive activity process, or when there is a skipping of exon 14 happens, there you can get to see there is a loss of CBL binding site, there which subsequently go to the decreased ubiquitination. There you get to see the impaired receptor degradation, and thereafter it leads to increased MET signaling. So with this increased MET signaling, there is a lot of MET amplification and seen, and there is an increase in the MET protein, and also in the increase in the mRNA, you get to see the various genomic alterations present. So why it is important to look for the RNA based rather than the DNA based technology for the on the NGS, because of that there are various more than 150 different MET exon 14 skippings have mutations have been described. As you can see, this is the whole this is the exon 13 and exon 15, and between this is the 141 base pair of exon 14, and this is the amino sequence of nearly 141 bases, but the alterations or the deletions happens between the nucleotide of sequence number from 963 to 1009. So at the 3' end, that is at the acceptor site, that is the splice acceptor site, you get to see the deletions, maximum deletion at around 41% as compared to the 5' that is at the donor site, which is just about 11%. But the maximum mutations at the splice site donor site is being seen is around 48%. So you need to know what exactly you are looking for because of this exon 14 skipping. And when there is a Um, when there is, okay, I can just, I'll go back to this. I want to explain this slide. Okay, so when there is a exon 14 skipping or when there is a point mutation, you need to know that which platform, technology has to be used, whether it is a RNA based or whether it is a um, RNA based or whether you should look for the DNA based. So accordingly, actually both the techniques are important. You should look for both RNA based as well as a DNA based, because if there is a whole lot of exon 14 skipping mutation skipping, then there is a fusion formed between the exon 13 and the exon 15, and this the fusion only can be seen at the mRNA level. But however, as I said, there are a lot of mutations also present, point mutations on the DNA. You need to have the DNA based testing as well. So to analyze the genomic variants that which alters or eliminates as a splicing site. So there are, as per the Caucasian population, there is only 3 to 4% of MET exon 14 skipping. But since now that there is a targeted therapy available like capmatinib, it is being used as an important biomarker as per the NCCN guidelines. So the NCCN guidelines also suggest that the there should be the testing of the MET exon 14 at the RNA level as well as at the DNA level, so that none of those point mutations or the fusions are been missed. So there are various methodologies to detect, like you can look for the RT-PCR genomic sequencing, you can do the RNA and exome sequencing, you can do the whole exome sequencing, and on the at the targeted panel you need to have either the amplicon base or the hybrid capture base. But the most preferred one is the hybrid capture, because since there are a lot of the fusion which is there, which can be easily detected by the hybrid capture method. So there are for the amplification, which is also an important factor to look for the protein expression, because of the poor screening, IHC is not advisable, but the FISH can be used to look for the various amplifications. But however, it has its limitations, like because of the detection limitation, because of the certain genomic alterations only can be looked upon. NGS, yes, a high multiplexing, it has a high multiplexing capability, but however, there is a long turnaround time and it's a expensive. But most of the time, the NGS is the preferred method which should be looked upon. So what everybody knows about now what NGS is, but the advantages are like it is a broad, rapid and parallel testing for all biomarkers of interest. And however, there are number of challenges which are faced when you are doing the NGS. Right now, there are no currently validated panels available for to know to detect these oncogenic mutations and the types of mutation within one test. Many testing labs do not have this technology. However, the costly specialized equipments are essential. So so what are the paths? As I explained this slide, I will skip this. So why is it important to include MET exon 14 skipping? Because the accurate detection of MET exon 14 requires a well-designed approach to cover the diverse genomic events varying in size and position that lead to exon 14 skipping. So the hybrid capture method is the most adaptable method for the either to detect for the DNA or for the RNA approach. So we have to be very careful while using the commercial amplicon based NGS method, because it is not reliable for detecting the MET exon 14 due to its false negatives. So this is the panel which is being advised by the NCCN guidelines. Apart from the EGFR, ALK, ROS, BRAF, we need to have the MET exon 14 and the RET testing. So and the as per the NCCN guidelines, we need to have the reports within the 10 to 14 working days of the biopsy report which is done. Also, the liquid biopsy is also one of the tests which is preferred, because if there is a shortage of tissue, because especially in lung, we can also do performed by the liquid biopsy testing. Of course, it has its own limitations because there is low variant allele frequency, it is highly fragmented because of the small base pair size, and it needs for test for standardization. But however, the concordance sometimes is limited between the liquid and tissue assays. So this is the by doing liquid biopsy and tissue testing, concordance is being heavily studied, and many studies show significant concordance which can be achieved between these two different different types of assays. So I would like to thank Novartis because it has explored various large panel by using the ALK, BRAF, EGFR, ERBB2, KRAS, MAP2K, MET, and RAS, PIK3CA, ROS1, and TP53. And apart from that, fusions like NTRK, ALK, RET, and ROS1. As I mentioned, that MET exon 14 has to be looked at the DNA as well as the fusion level, because at the RNA level, because if there is a whole lot of exon 14 skipping, only it can be detected through the fusion that is at the RNA level. Thank you so much.